Hello, and welcome to a instructional session facilitated today by the Digital Anatomic Pathology Academy. I'm Dr. Louis Hassel, and our discussion today will focus on some of the basics in differentiating cervical dysplasias, particularly in the, of course, in the squamous precursors for squamous carcinoma. As we talk about this, it's important and we assume that there's some basic understanding of the pathobiology going on. But we'll talk here a little bit about the nomenclature and some of the evolution of that so that we can apply these terms more successfully. So we have several parallel systems of nomenclature in place. There is the dysplasia term, that has been around for quite a time, since the era of Papanicolaou. And that's generally grouped into three groups, although originally the severe dysplasia and carcinoma in situ terms were separate. We also have the intraepithelial neoplasia modification, also known as the CIN groupings, which corresponds to CIN 1, 2, and 3, and that's still in wide use because it has some correlation still with the and acceptance within the most recent iteration of this topic, which is the lower anogenital system, which is intended to be applied towards these squamous lesions in the cervix, vagina, vulva, and anal regions on the female, as well as comparable areas in the male. Because of the complexities of and the challenges with reproducibility, this system moved towards a two-stage proposal and separated off only the low-grade lesions from the high-grade lesions. These terms, low-grade SIL and high-grade SIL, derive from the Bethesda system, first introduced in 2001. And then adopted in the lower anogenital system when that was published about 12 years ago. Of note is that within the last system, the use of P16 immunohistochemistry can be quite useful, since that seems to correspond here between the low and high grade lesions, which are usually negative in the low grade and positive in the high grade lesions. This information also tends to correspond to what we find with HPV types, since low-risk types tend to be more frequently associated with low-grade lesions, whereas high-risk types sort with the high-grade lesions most consistently. And that, of course, corresponds to risk and the rate of progression of these disorders into invasive cancer. From a conceptual point of view, this corresponds to this commonly used diagram, which attempts to illustrate the differences between these categories: normal, mild, low-grade dysplasias, moderate, severe, in situ, and then ultimately invasive carcinoma. And we know that there are different molecular events that are occurring in here, such as the presence of viral production or shedding, and then corresponding to the high-grade lesions are usually viral insertion into the DNA and loss of surface maturation in these lesions. However, I've emphasized here that there are no sharp boundaries with these lesions, and that that is the problem with reproducibility. When you have a 4 or 5 or even just a 3-stage difference. So dividing the things here between mild, low-grade, normal, and high-grade up to invasive carcinoma is much more reproducible, much simpler classification scheme. And so I emphasize that this diagram is for classification. This does not mean that the viral infection produces first a very mild dysplasia and that progresses over time to become in situ carcinoma, whereas in fact we believe that many of the high-risk lesions may become infected and incorporated very early without a precursor of very mild dysplasia. And indeed some invasive carcinomas can be seen with overlying moderate dysplasias or keratinizing dysplasias, as we will mention later. So let's just talk a little bit about some of the distinctions. And first of all, let's jump to CIN3, because I think this is perhaps the easiest thing and certainly the most important thing to recognize for trainees who are trying to master and copy the skill of their mentors in becoming reproducible and attuned to the standards here. So with CIN3, we typically have a uniform cell population from top to bottom with really no evident maturation, very minimal or no maturation. We will see mitotic figures at or above the mid-level of the epithelial mucosa, and we will often see atypical mitotic figures. Going along with this, there will be nuclear hyperchromasia, and these cells get smaller. This decreased nuclear size and high NC ratio is characteristic of that. This corresponds to what's seen on the pap smears as well, where these are small hyperchromatic cells and can frequently be missed if they're floating in between other cell groupings on a liquid preparation, for example. In terms of differentiation, the things that we might confuse with this would be atrophy. An aged patient with a very thin mucosa and smaller cells could appear somewhat like this. Also, transitional metaplasia, relatively uncommon, and a very immature metaplasia, both can be confused with CIN3. So with that introduction, let's look at some slides and some cases and use our classification scheme here to dive into a case like this. So here we see the digital slide. We see a normal squamous mucosa out here on the edges. We see some inflammation here. And then down here, we see an area of increased blue staining. So that's always a good marker for something that's different. And as we go here to higher magnification on this particular area, let's just check off the list here. Well, we don't see any real evidence of maturation in this area. We see cells that are smaller than adjacent areas, certainly smaller than the squamous mucosa that we saw here in the more normal exocervix. We see these cells over here have nice maturation. So that's the difference with maturation. Then let's go down a little higher magnification and just see what we can see relative to mitotic activity and NC ratio. So here we can see a mitotic figure, here we can see mitotic figures, here's an atypical mitotic figure, another mitotic figure. So here's one high magnification field with an enormous number of mitotic figures, and some of which are atypical. Without maturation, with hyperchromasia, and some variability in nuclear size, but generally the nucleus seems to dominate the overall cell size. So this fits nicely into the category of CIN3 or HSIL. Now, adjacent to it here, we have an area that does show, or may suggest it shows, a little degree of maturation. And so we always grade on the worst area. We don't grade on this area and say, well, there's some mild or moderate dysplasia here, and overlook the severe high-grade dysplasia that we have over here. So always grade based on the worst area that you see. Well, let's try another example and see how well you can do with that. So here's a typical cervical biopsy. We see two fragments of tissue, and we can see here at low magnification that this one seems to have a relatively normal appearing squamous mucosa. There's nice maturation towards the surface, whereas this one's a little bit bluer. Here you can see that subtle difference between over here and here. So let's go down and look on this area and say, do we have maturation? No, these nuclei are all pretty much vertically oriented, a little bit of jumbling, maybe a trace of horizontal change on some of these cells, but not much, really not much that we can identify. Do we have suprabasilar mitotic figures? Well, there's one right there, right near the surface. Here's another atypical one over there. It's looking a little further. Here's one in the mid-level here where we're getting a little bit of maturation over here. So again, as I'd said before, we may have a little bit of CIN2 formation. What about the nuclei? Is the NC ratio high, low, intermediate? Well, this is pretty high. Most of what we see is nucleus here. We see very little cytoplasm, and so this would again qualify as a high-grade squamous intraepithelial lesion, CIN3, severe dysplasia, all of those synonymous terms based on this finding. Now, we do look in these circumstances to see whether endocervical glandular spaces are involved. That's a prognostic feature for recurrence. And we don't see that in this particular case, but if we were to see it, we would mention it. Let's go on then and look at the other extreme. Let's talk about CIN1. Well, so with CIN1, this looks nearly normal. We do have some increased basal and suprabasilar mitotic figures, but we don't see any atypical mitotic figures. Seeing an atypical mitotic figure with a subtly increased suprabasal proliferation should move us to think more towards a higher grade of dysplasia and a higher risk HPV type. We will see some nuclear enlargement, but there's still a lot of cytoplasm. The nuclei may become somewhat crinkled or wrinkled up, forming raisin-like structures, or what we call coilocytes when they get pronounced perinuclear clearing. In conjunction with that, if we find two nuclei in that clearing, a sort of a double nucleus, that also is a supportive feature. And here in this situation, the NC ratio remains fairly low, more cytoplasm than nucleus. Now with this disorder, the usual differential is between just glycogenated mucosa that have so-called pseudocoilocytes. So let's take an example and take a look at a couple of these lesions under the microscope. So here's a biopsy. We see a single piece of tissue here, and we'll go down and take a look and see, you know, this looks pretty normal here. So what is it that allows us to call this dysplasia? Well, as we look here, we see that the proliferation zone is slightly expanded. Here's a mitotic figure that is just slightly above the basal layer, and we could find another one or two. Increased mitotic figures at the basal layer, there's another one. And then as we look up here towards the surface, we get this wrinkling of the nuclei and occasional double nuclei. So here's one where we have a double nucleus. Here's a little bit of nuclear enlargement here and here. And so these cells are slightly larger than the normal superficial cells. The nucleus is enlarged, and it's a little bit darker. So it's a subtle change, but this qualifies, I believe, as a low-grade squamous lesion based on the findings that we've just ticked off for you. And of course, the differential here would be with normal glycogenated squamous epithelium. That would usually not have the double nuclei, it would not have the nuclear enlargement. It may have these nuclear cleared areas that which will be filled with glycogen and can be quite misleading at times, but it will not have this wrinkling and binucleation that we see here. Let's take another example. Here's another one where it looks fairly normal. We don't see a lot of hyperchromasia. And let's go down at higher magnification and just look at that proliferation zone. So sometimes we have to go to higher magnification a little bit more slowly here. So let's ask the question, do we see suprabasal or mitotic activity here? Not a whole lot. There is also some inflammation here and some hyperplasia. This does appear to be fairly active. That may be a mitosis there. We can go along, and so there's not a lot of mitotic activity here that we're going to see. And when we're in doubt, if the differential is low grade versus normal, sometimes a Ki67 stain will show increased labeling of the basilar keratinocytes. and some suprabasilar labeling as well. Here we see a mitotic figure that's nicely above the epidermal submucosal border. Then do we have nuclear enlargement? Do we have binucleation? Well, we certainly have some nuclear enlargement up here. We can see here's some cells that are fairly large still. At this superficial level, these should be very compact, small nuclei rather than this more open chromatin pattern. This may be a binucleate cell here. And here we see this sharp perinuclear clearing around these nuclei that tends to be sharper in these koilocytes as opposed to pseudokoilocytes, which have maybe a more shadowed area like this cell. So contrast what these sharp boundaries look like with maybe this more graded change in some of these other cells. So that would qualify as a low-grade dysplasia. We can look at the other side of this lesion as well and see if we have the similar changes here. We do see again some of these prominent perinuclear clearing areas, some enlargement of the nuclei, and I think if we were to look long and hard at this, we might find some increased mitotic activity in some of these suprabasilar cells, perhaps right in here. I believe there's some here. But we didn't see any, there's one right there, any atypical mitotic figures. Now, this is getting a little bit higher. If we were up in here, we might be forced to call this moderate dysplasia or CIN2. So there's two examples to work through and study and think about in terms of CIN1. So that leaves us with CIN2. And as is with many intermediate grades, it's more than CIN1, but it's not quite as bad as CIN3. Certainly anything that has atypical mitoses or mid-level mitotic figures is at least CIN2, and then we would want to make sure that we don't have other areas of CIN3. These nuclei are enlarged, they're somewhat pleomorphic, but they still show some degree of surface maturation, sort of flattening out of the nuclei and spreading a little bit broader. They still have a relatively lower NC ratio. So while the nuclei are shrinking down and maybe a little smaller than the CIN1 nuclei, they're not as small as the CIN3 nuclei, and the amount of cytoplasm is still moderate to high, so that NC ratio still remains lower than with CIN3. However, since management of these lesions is not particularly different from CIN3, the really important distinction is to make sure that this is not CIN1. Because once we call it CIN2 or greater, that's going to take the patient down a different management scheme in terms of testing, follow-up, potential surgery, ablative procedures, and so forth. Now, another thing to remember is that CIN2 is often seen in conjunction with CIN3, and so you want to make sure you look carefully to make sure you haven't got an area of CIN3. In terms of differential diagnosis, I think perhaps the most important one is this keratinizing dysplasia. With keratinizing dysplasias, you can get a lot of large cells and a lot of apparent maturation on the surface. It's keratinizing, of course. And the NC ratios are not like CIN3 that we just looked at, but these keratinizing dysplasias can develop directly into invasive neoplasia. And so that's an important one not to miss and not to confuse with just CIN2, to make sure that it's not a keratinizing dysplasia. And then other immature metaplasias can also occasionally look like CIN2. So that's in our differential considerations as well. So let's see if we can take a look at an example. We've seen the area of CIN2 in the prior CIN3 case. This is another case that's maybe a little bit more similar to that, as we'll focus first on the surface here. And we see here that we do have some degree of maturation. We have a proliferation zone down here, and then there's a transition as these cells sort of become a little flattened out and tend to become more horizontal. So this would be pretty good for CIN2, And we may have a few mitotic figures up in here. Notice, though, that here we still see quite a bit of cytoplasm in the basal layers as well, occasional dyskeratotic cell and so forth. And we may find, if we looked closely enough, some atypical mitotic figures, not as easy to demonstrate on this digital slide as perhaps under your own microscope. Here's a slightly atypical mitotic figure right there. This, I think, fills the concern for CIN2 in this surface area with sort of mid-level atypia maturation on the surface. What I skipped over, though, as we were diving down to high magnification, and that's a pitfall that you have to be aware of, is this area right here. That's bluer than this. It's more solid than this. And so look at this. These look like they're still glandular spaces. There's some glandular epithelium here. We see still some here. So this is an area where the dysplasia involves the endocervical gland. And since this doesn't show much evidence of maturation within this glandular space, and since we still see plenty of mitoses, this area could even potentially move you to call this CIN3. Here's more of these mitoses. We do still see a trace of maturation towards the center of some of these areas, but we don't see any other features of invasion. Now, we'll talk on a subsequent video about markers of invasive neoplasia and differentiating that from CIN3. Here's an area where, the CIN2 does involve the endocervical space, as we see this squamous epithelium down in here with mitotic activity and some still enlarged cells, but at higher NC ratio than with CIN3. So that gives you a nice roundup of CIN3, CIN1, and CIN2. Of course, the challenge is seeing enough cases that you become confident in making those distinctions and continuing to test your grading with those of colleagues and peers to ensure that your cut points are appropriate and will not skew the management curve of your gynecologist that you're serving. That's an important thing to remember. I still remember the time when a dermatologist told me that when I joined the practice in that area, suddenly the rate of squamous cancers in his practice went sky high. So you don't want to be that, get that kind of feedback from your colleagues when they come to you and say, has something changed? Because now everything seems like it's CIN3 or CIN1. With that, we'll conclude. Thank you for joining us today on this, and I hope that that's brought a few things into focus. Please subscribe and add your comments below. Share this with your colleagues who may be struggling to make the difference between the forest and the trees in these challenging cervical biopsies. Until next time, thanks for joining us.